Welcome to Weekly Neurology Deep Dive. This program is produced by Amer Gavanini. And I do want to state right off the top that this deep dive is strictly for educational purposes.
Exactly. There is absolutely no commercial goal here.
Right. It is only a summary, so you are highly recommended to read the full paper we are discussing today. And while the paper discussed today is relevant to all areas of medicine, really providing valuable insights for your daily clinical practice.
I mean, it is an incredibly important topic.
It is. So we are reviewing a paper titled Comparing Civil Legal Actions Among International and Canadian or American Medical Graduates in Canada, a retrospective cohort study.
And that is by El Sharif and colleagues, published in the British Medical Journal, Open in 2026.
Well, for those of you who are short on time, I want to start with a concise, practical summary. This paper leverages data from the Canadian Medical Protective Association to compare civil legal action rates and outcomes.
Specifically looking at the differences between international medical graduates and Canadian or American medical graduates.
Exactly. And the study found no significant difference in either the rate of civil legal cases or the outcomes of those cases based on where a physician obtained their medical degree.
Which is a massive finding. But we really need to move from that practical summary to the broader medical workforce landscape.
I agree, because understanding these medical legal risks is crucial for addressing modern physician shortages.
It is. I mean, modern physician shortages are a daily reality. And evaluating these workforce dynamics directly impacts how we recruit and retain practicing neurologists.
Well, the demographic reality really sets the stage here. Currently, over 25% of physicians in Canada and the United States are international medical graduates.
And, when you look internationally, it is even higher. That number is over 40% in the United Kingdom, Ireland, Australia, New Zealand, and Norway.
So we are talking about a massive portion of the medical workforce, but this brings up a real paradox in the field.
It does, because previous research clearly demonstrates that the quality of care provided by international medical graduates is completely comparable to domestic graduates.
And sometimes it is actually better. I mean, prior data shows lower mortality rates for conditions like pneumonia or acute myocardial infarction when patients are treated by international medical graduates.
Right. The clinical data is very reassuring. But despite that data, international medical graduates frequently face persistent negative stereotypes.
They really do. They have to navigate assumptions of inferior training, systemic discrimination, and, well, an increased risk of professional regulatory college disciplinary actions.
And that last point is where the literature gap comes in. Prior studies focused heavily on that regulatory college discipline.
Which usually involves ethical breaches or documentation issues, right?
Exactly. But before this paper, no studies had explored civil legal claims, which are directly tied to perceived patient harm.
Well, I have to ask you about that. Since regulatory college complaints often focus on administrative or ethical issues, does analyzing civil legal claims provide a much more objective measure of actual clinical competency and patient harm?
That is a great point, and yes, it absolutely does. Regulatory colleges handle everything from billing disputes to staff conflicts.
Which obviously do not reflect the actual clinical care provided to a patient.
Precisely. A civil legal claim requires a patient to perceive direct physical or severe psychological harm from a clinical encounter.
So, by focusing entirely on civil legal claims, this paper isolates incidents rooted in patient harm.
Exactly. Because civil legal claims are the true indicator of perceived patient harm, the authors built this massive national-level study to investigate this exact metric.
And the scale of this data is just incredible. The data origin is the Canadian Medical Protective Association National Repository,
Which covers over 95% of practicing Canadian physicians.
It is about as comprehensive as you can get. So to analyze this, they used two distinct multivariate, multi-level models. Let us break those down.
Well, the first one is the case rate model. It examined the years 2015 to 2019.
And they looked at 433,038 physician year observations.
I mean, that represents 98,960 physicians. It is a staggering amount of data, capturing 7,657 civil legal cases.
And for this first model, the specific outcome was civil legal cases per physician year.
Right. Then you have Model 2, which is the case outcome model. This one examined the years 2016 to 2023.
And for this one, they looked at 8,046 closed cases.
Exactly. And the outcomes here were categorized into three groups. It was either a dismissal, a decision in favor of the physician, or a decision in favor of the plaintiff.
Well, I noticed a detail in the methodology about the timeframes. The paper states there is a median 4-year delay between a clinical encounter and a civil case opening.
Yes, that delay is crucial to understand.
So could you clarify how this specific median delay necessitated using the 2015 to 2019 cohort for the rate model versus the 2016 to 2023 cohort for the closed outcome model?
I mean, it basically dictates the entire mathematical structure of the study. For the case rate model, they needed to measure how often a physician was named in a suit based on active practice time.
So they stopped the observation period at 2019.
Right, they stopped it at 2019, but extracted the data in 2024. That accounts for that median 4-year delay, ensuring almost all cases from that window had actually been reported.
I see. And then for the case outcome model, civil litigation just takes years to resolve.
Exactly. A case outcome is only known when it officially closes. So looking at cases that closed between 2016 and 2023 provided a reliable volume of finalized legal decisions.
Regardless of when the initial clinical encounter actually occurred?
Precisely.
Well, for a practicing neurologist listening, that is a stark reminder. A lawsuit filed against you today is mathematically likely to be rooted in a clinical encounter from 4 years ago.
It is definitely something to keep in mind.
So, with the massive scope of the 433,038 physician-year observations established, let us move directly into what the data revealed about the raw frequency of legal actions.
All right, looking at Model 1.
Providing the baseline here, about 98% of physicians had 0 cases in a given year. The mean case rate was about 0.02 cases per physician year.
And the primary finding from this rate model is really the headline of the paper. The difference in case rates between international medical graduates and Canadian or American medical graduates was not significant.
That is a huge validation. Where you trained did not increase your raw risk of facing a lawsuit.
Exactly. However, the study did identify control variables that were significantly associated with increased case rates.
Right, I have those here. Male gender was one, and having 5 to 14 years of practice was another.
And also practicing in non-family medicine specialties.
Yes, specifically surgical specialties, anesthesiology, obstetrics and gynecology, and medical specialties.
Which makes sense. I mean, those specialties routinely perform high-acuity interventions where the baseline risk of patient mortality is simply elevated.
And having 5 to 14 years of practice, that is the career phase where you typically manage your highest patient volumes, right?
Exactly.
Yeah.
You are taking on the most complex clinical cases,
Mm-hmm.
which statistically maximizes your exposure to adverse events.
Well, another interesting data point was that physicians aged 65 and older had significantly lower case rates.
They did.
I have to question this age-related data, though. Since physicians aged 65 and older have significantly lower case rates, could this be less about advanced clinical wisdom and more about a reduction in clinical volume or a purposeful shift away from high-risk procedures late in their careers?
That is exactly what the authors suggest. It is heavily tied to practice modification.
So they are just stepping back from the high-risk situations.
Right. Physicians in their senior years frequently reduce overall clinical hours or transition into administrative and teaching roles.
So by purposefully avoiding the highest risk procedures, their mathematical probability of being in a civil case naturally decreases.
Exactly. Now, having established that international medical graduates do not face legal action more frequently,
Yeah.
we really need to transition into exploring what happens when a case actually goes forward and is closed.
Right, which brings us to the findings on case outcomes in Model 2.
And we should start with the unadjusted data here.
So before adjusting for variables, cases favored the plaintiff slightly more often for international medical graduates. It was about 39% versus about 37% for Canadian or American medical graduates.
Yes, but that is the unadjusted data. The primary finding is what happens after multivariate adjustment.
And what did that reveal?
After multivariate adjustment, where the physician received their medical degree was not significantly associated with the case outcome. The odds ratio was about 1.
An odds ratio of about 1 means absolute parity. I want to challenge that initial unadjusted difference, though. The disappearance of the plaintiff-favored difference after adjustment is a critical finding.
It really is the most important takeaway.
Doesn't this highlight exactly why controlling for variables like case severity and communication factors is so essential, especially since physicians new to a health system might face unique systemic barriers that have nothing to do with their baseline medical knowledge?
I completely agree. Controlling for these variables is mathematically essential because raw percentages hide the true systemic drivers.
Like differences in patient demographics or hospital resources?
Exactly. An international medical graduate might practice in an under-resourced environment, or they might face systemic biases during the litigation process itself.
So the multivariate adjustment mathematically neutralizes those external imbalances.
Right. It isolates the physician's specific clinical actions And when you isolate those actions, the location of the medical degree has no significant bearing on the outcome.
Well, the paper also details what actually does drive a case outcome in favor of the plaintiff.
And the data was very clear on this. There was a significant association with the severity of patient harm, ranging from mild harm to death.
Which is expected, but the data also pointed heavily to contributing behavioral factors.
Yes, behavioral factors are massive drivers here. Unprofessional conduct, insufficient skills, and poor communication with patients or other physicians.
I mean, if a physician demonstrates poor communication, the legal defensibility of the medical care just plummets, doesn't it?
It absolutely does. The civil legal system heavily penalizes those behavioral and communication deficits. Totally. Regardless of the physician's country of training.
So as we wrap up, we should discuss the study's strengths. Using the Canadian Medical Protective Association database is obviously a huge strength.
Definitely. A comprehensive national database covering over 95% of physicians is incredibly robust.
And the use of hierarchical models allowed them to effectively account for provincial variation in legal systems across Canada.
Right. But we also have to acknowledge the limitations. For instance, the lack of data on specific licensure pathways.
Meaning they couldn't assess the direct impact of different evaluation protocols.
Exactly. And the inability to distinguish immigrant graduates from citizens who went abroad for medical school and returned.
Right. Plus, they omitted system-level contributors to medical legal outcomes, like hospital understaffing.
Which definitely plays a role in patient harm, but was outside the scope of this provider-level data.
Well, it is time for our final practical summary. Based on a massive national data set where a physician receives their medical degree has absolutely no significant effect on their risk of facing civil legal actions or the outcomes of those actions.
It is a definitive conclusion that should help dismantle some of those negative stereotypes we discussed earlier.
I hope so. And I will leave you with a final question to ponder in your own practice.
It is an important one.
If the data shows that civil legal risk is primarily driven by communication deficiencies and behavioral factors rather than the location of clinical training, should continuing medical education for neurologists pivot aggressively toward interpersonal communication and system navigation rather than focusing almost exclusively on purely clinical updates?